Welcome to Muted in Medicine, the podcast where we break the silence on the untold stories and pressing issues within the healthcare profession. Join us as we dive deep into topics that often linger in the shadows of medical corridors and are not discussed in conferences, meetings, social gatherings, and in the hallways. They are often hiding. From navigating errors and facing litigation to the often overlooked realm of mental health among healthcare professionals. Through candid conversations and storytelling, we aim to amplify the voices and shed light on challenges that resonate across the medical landscape. So grab your stethoscope and a cup of coffee and tune in as we uncover the layers of complexity in the world of healthcare that are so muted yet so profoundly impactful.
Hello, everyone, and welcome to Muted in Medicine, the podcast where we break the silence on untold stories in healthcare. My name is Saba Fatima, and I'll be your host for this podcast. I'm a pediatrician with a passion for helping healthcare professionals facing secondary trauma at work in healthcare, which often they're unprepared to face. I hope you're liking some of the content that we've been producing. Please subscribe to our YouTube channel if you do like it, and let us know more recommendations for what you'd like to hear next. Today, we're talking about something that's hard to face, even harder to talk about, when medicine can no longer change the outcomes for our patients. What do we do when medicine can prolong life but not improve it? And who gets to decide when it's time to stop? Medically ineffective treatment, a phrase that might sound clinical but touches on some of the most deeply emotional and ethically complex decisions we face in medicine. These are the cases that weigh heavily on clinicians, the patient who's had every intervention, the family pleading for more time, the care team quietly questioning whether continued treatment is helping or simply prolonging suffering. In these moments, medicine reaches a limit, and ethics must guide what science alone cannot resolve. Whether you're a healthcare provider who has stood at the bedside or a listener or patient trying to understand how we make sense of death and dying in modern medicine, this is a conversation we all need to have. We are joined today by Dr. Alyssa Burgart, a pediatric anesthesiologist, associate professor, and nationally recognized bioethicist at Stanford. Her work centers on guiding families and care teams through some of the most difficult decisions in medicine, with a deep commitment to justice, compassion, and trauma-informed care. From end-of-life decision-making to algorithmic bias and reproductive justice, she approaches medicine with an unwavering ethical lens. Dr. Burgart writes about the ethics and culture of medicine in her newsletter, Poppies and Propofol. Together, we'll explore what it means to call a treatment medically ineffective, how families and clinicians can navigate these moments of uncertainty, and why ethics is not about having all the answers, but about asking the right questions. Dr. Burgart, welcome to the show.
Thank you so much for having me. What a delight.
Yeah, and we ask everybody when we start, what's bringing you joy in medicine today?
Supervising two junior ethicists, like people who are new to the practice. And, for me, there's not a lot of ethics consults now that are new to me or that I've never seen anything like it before. And so it's actually really fun to see it through their eyes as something that's very brand new. And I'm enjoying that lately.
That sounds great. Yeah. It's something that we all thrive on, I think, also, like teaching new people. I want to start by asking you, just a bit about your background and what drew you to the topic of ethics. I always like to know the guests first, before we start talking about the topic.
Well, I was raised in a religious household. I was raised Catholic. I attended Catholic schools in Los Angeles. And, a big part of my education was really talking about what's right, what's wrong, what does the church teach about something, what does secular ethics teach about something, and I thought that was just very interesting. And so when I had an opportunity to study bioethics as an undergraduate student at the University of Judaism, I just thought that it felt like just such a great fit for the things that I was most interested in. At the time, I was thinking I might become a doctor. I wasn't quite sure at the time, and so I thought, I really like to dig into whatever the hardest gray area is. Like, I'm like, ooh, let's look closely. So that
Yeah.
really made that possible for me. And I had a lot of really wonderful experiences in my undergraduate degree that led me to the career that I've built today.
Yeah, that's awesome. And yeah, I could say you enjoy doing that still. Yeah.
I do. I do. I think it's really, I wanted a life of meaning and I wanted a career of meaning.
Yeah.
And being a physician is a beautiful way to do that. And I still love being a doctor and I love being an ethicist. It's
Yeah.
been really, I certainly don't ever wake up and think that what I do doesn't help anybody or isn't meaningful.
Yeah, that's awesome. I think that's a great achievement. Yeah. Um, how do you define medically ineffective treatment in your clinical practice? And I know we had the conversation offline and you talked about that would be the correct word, medically ineffective treatment. So how would you define that?
Yeah, well, and actually, just to kind of ground folks, the reason that we ended up talking about that in particular is because the word futility is still gets kind of bandied about. And back in the early 2000s, this was a huge topic. The Texas Advanced Directive Act had just really launched, and there was really a national conversation going on around cases like Terry Schiavo and other cases around what just because we can do something in medicine, should we? When should we not? And so conversations around medical futility, the idea that if the things that we're doing are no longer going to be effective for the patient, really evolved. And then
Oh,
in the time since then, the word futility has a lot of negative connotations to it. It's very value laden. What somebody thinks is what one person thinks is futile may not be something that someone else believes of as futile. So as
sure.
we've continued to explore this in medicine and in ethics, the language that's really evolved is medically ineffective treatment or medically ineffective care.
Yeah.
And part of why that's important is it's more descriptive. So just like we're getting away from referring to diseases by the names of older gentlemen who came up with them, we are also in the same way in ethics trying to use descriptive language, trying to use words that mean what they sound like,
Yeah.
and just being more clear.
Yeah, that sounds good. So, do you remember a case where, a case that really stood with you during your work with ethics where you thought that the treatment was ineffective? And just as a example for our listeners.
It's something that comes up a lot, especially in my adult practice.
Okay.
There's many, many people who are in the ICU, are critically ill, and unfortunately who, despite all of our best interventions, all of the things that we have to offer, there are people who are not going to survive that stay in the ICU.
Right.
And it's always really challenging to, for our ICU clinicians to really support the people who love that person through that process.
Right.
So I wouldn't say that there's a case that necessarily sticks out the most. I think they're a tragedy every time because we would much rather reach a shared decision where a family decides that recognizes what the clinicians are sharing, that the illness is not survivable.
Right.
But when a clinician decides that they need to invoke this concept of medically ineffective treatment, oftentimes it's because they cannot seem to reach a shared decision with the patient's decision makers.
Right.
And the clinicians say, hey, as a moral agent, as a person who has ethical responsibilities, I no longer feel that I can keep going doing these things to your loved one that I don't think are working anymore. They're not
Right.
achieving the goals that this patient had for themselves. They're not achieving, we don't believe they're going to survive to get out of the ICU other than when they die. And so it's really challenging when there's been so much disagreement and inability to reach a decision or a shared understanding of what's happening. And so when a clinician reaches that point, it's usually a pretty difficult case.
Yeah. And when we're making those decisions, do you think those are objective decisions or value laden? Like, what do you think?
It's interesting. As a as an ethicist, we give recommendations. So I'm an anesthesiologist, but I don't tell other doctors how to practice medicine. I don't tell them what their own values are, but I try to explore their values with them. I try to explore values with families. Medically ineffective treatment oftentimes is under situations where, let's say you have a patient where they're on a ventilator and we just cannot see, they're in multi-system organ failure. We don't think that they're going to survive. They're in kidney failure, they're in renal failure, they're not breathing on their own. Maybe they have a cardiac condition. And so oftentimes these patients, they're on a ventilator, and oftentimes they're also on, medications that are keeping their heart going, keeping their blood pressure up where it needs to be. And so there comes a point where these things start to also, we know that all of these things have risks on their own. They're supposed to be temporary interventions to help a patient ideally, survive and recover to the greatest degree possible. So there are times when I think it is very clear-cut that a patient is unlikely to survive the hospitalization. There are other times where we get these consults. Our hospital requires an ethics consult to go through this process, and part of that is to protect the patient and the family's rights to make decisions, because the default is that patients and families make decisions. And so it can be, there are times when clinicians call and it doesn't seem so clear-cut. And it seems like maybe the patient could survive. Let's better understand what are all the things that would have to line up for that to be possible. And are those things where there's enough of a likelihood that if a family said, hey, we know you don't recommend that we go down this path, for example, of maybe a tracheostomy, maybe needing to have long-term certain types of support. So we try to work with our clinicians to better understand, is this something where we're so certain that this patient is not going to survive? Or is this an area where there's less clarity? We also require, and I work in California, and so California law and policy are the things that we use here. And, we also utilize a second opinion. So it's not just one person totally on their own saying, this is the decision that I've made.
Yeah. And as an ethicist or as a clinician, like what advice or what wisdom would you give, when there's conflict between what the clinician is thinking and what the family is thinking? And, there's also a lot of other factors like cultural and religious and other factors.
Absolutely. We see a lot of, one of the things I love about medicine is you meet all different kinds of people. You meet people who speak all sorts of languages. You get to, interface with every person, people at every class, every race, every religion. And I find that really invigorating. And I think it's really challenging when you have a busy ICU service, for example, and there's a lot of competing interests. This is why our teams really need support from people like chaplains and social workers and respiratory therapists to make it possible for us to all kind of work together. But in terms of, usually our service is involved before we ever get to this point of a clinician saying, hey, I think we're in an intractable disagreement. And so a lot of times when we're meeting with families, I always try to infuse a trauma-informed care perspective. Like, what is this family going through? Most of the time, the patient can't speak for themselves in these situations. They're usually too sick to be able to do that. A lot of times people, like I said, have a breathing tube. So we try to really talk with families to say, hey, help me understand who this person is, what are the things that matter to them, so that we can really support the family in making a substituted judgment for the patient.
Okay. And at that time, when you are facing that conflict, I think I'm trying to understand then who gets to decide, who gets the ultimate decision.
In the way that it works in California, and each state has a different process. Not all states have a process.
Yeah.
And so it's important for your audience, wherever you're working, it's important to understand your local context. I'm going to speak to my experience in California just because that's where I have the most expertise. But it's when it's an unshared decision. So the standard is that the patient makes decisions for themselves.
Right.
And if the patient can't make decisions for themselves, their healthcare agent gets to make those decisions.
Right.
Person might have an advance directive where they say, hey, I want my husband or my wife or my brother or my cousin or my friend to make my decisions on my behalf if I can't do them for myself.
Mm-hmm.
When a person in that position as a clinician, we offer, let's say, different options for care, or we say, hey, this is our recommendation. When that person tells us they consent to it, they don't consent to it, that's called a healthcare directive. So the person's telling us, yes, you have my permission to do this thing, or no, you don't have my permission to do this thing. And obviously, clinicians are doing this constantly, where they're making decisions with patients and families. When we reach the point that a clinician thinks, hey, we have been trying to work through this process. We were hoping the patient would get better. We no longer think that's possible. We think that the things that we're doing are more harmful, and the likelihood of benefit for the patient is just getting less and less. That's when that clinician might invoke medically ineffective treatment. So when somebody does that, it's not that that person gets to just automatically override this patient or their family. We go through a process. And so the clinician needs to share with the patient, I don't think it's ethically permissible for me to keep doing these things to this person. I'm concerned that we're no longer getting the benefits we want. We talked before, oftentimes, many times, about what this person's values were, what it is that their hopes were for recovery. And I wish we were able to do those things, but we're not. We don't think that's possible, and we don't think they're going to survive.
Mm-hmm.
And so that clinician can start this process of medically ineffective treatment. And what that means is that the family or the patient has an opportunity to say, okay, well, if you're not willing to provide this service here, ongoing medical care, then they have an opportunity that they could look to see if they could be transferred to another facility.
Sure.
Oftentimes, I would say the majority of times in my experience, when we're at this point where this person is very near death, they have oftentimes, like I said, multi-system organ failure. It's very unlikely in those cases that another hospital will be willing to accept the patient, because they're going to say, we don't have anything different to offer. You're already doing all the things that we would offer. So if a transfer can't happen, that's when, usually at the beginning of this process, a date is set to say, okay, we're going to look for a transfer for the next few days. If we're not able to do that, then on this particular day, we are going to make sure we're going to switch the patient to comfort care. We're going to withdraw the ventilator in a way that honors their dignity, and we're going to stop this process.
Okay. And when you approach, so you work with children as well, because you're working in pediatric anesthesiology. I'm just wondering, what is a compassionate way? So you talked a little bit about what the clinician would say, but what is a compassionate way? I just want to hear from your perspective to approach these families and talk to these families, because I'm sure it's very difficult. It's probably hard on you as well, because you're, and I want to talk a little bit about that and as we go along as well. But I just want to know, what is a way that you approach these families?
I mean, first of all, I agree with you. It is hard. And I think when you see family, as clinicians, like we're constantly interfacing with people suffering, right? Like it's everyone's worst. No one's having a good day when the person they love is in the ICU. It's not a good day.
Right.
But for us, we're just going to work. Being in the ICU is totally normal for us. So there's that dichotomy that I think is always present in these conversations.
Right.
So I do my best, first of all, to always treat people with dignity and respect.
Yeah.
To really try to understand what values and goals are present in this moment so that we can really center those.
Yeah.
And I really try to listen for the emotions that people are experiencing. If somebody says they're afraid, for example, like to me, that's a flag that I need to pay attention to. I don't gloss over that. I want to say, okay, tell me more about what you're afraid about. Anybody would be afraid who's in your situation, of course. Obviously it's not the same thing that you say every time, but really trying to listen to families deeply for the meaning of what it is they're trying to say and the meaning of what it is that they're worried about. Because certainly by the time we're having a conversation about potentially medically ineffective treatment, I mean, we're talking about what sort of time might a family be sacrificing to believe that there's a chance their loved one might recover, even if the clinicians don't think that that is likely to happen. And it's hard, I just try to take it very seriously and to really listen to people for the meaning of what they have to say. Always surround the dignity of the patient and the dignity of their family members, and really honor how hard it is to be in these positions. We always say, oh, do an advance, we want you to have an advance directive, know who's going to make your decisions for you. But it isn't like there's any coaching that happens or preparation for anybody. Sometimes we're dealing with like the adult children of people. Sometimes you have somebody who's 21 years old who's like carrying this huge burden for their parents.
Yeah.
You have sometimes parents who are bearing this burden for their adult children, or their pediatric children. So really trying to. I just think it's such a. I think conversations around birth and death, in particular, are really tender.
Yeah.
And I try to bring that tenderness to those conversations.
Yeah. That's really thoughtful, and I think it's thought-provoking for our audience as well. So thank you for sharing that. I kind of want to go back to a little bit about the religious, if there is like a religious belief or something that's guiding the family's decisions, because I know there in some religions, there's maybe the concept that you can't end life yourself, like that. Does that come a lot? And is there like some exception for that, or no? Like if there's a strong religious belief which is causing them not to withdraw care, families, or no?
It depends, and there's it depends. So we meet people obviously who have lots of different faiths, lots of different faith traditions. A lot of people, of course, believe in a miracle. They're hoping for a miracle.
Yeah.
And I find that some clinicians struggle a lot more with that language of a miracle and hope and
right.
The frustration sometimes that a family has not come to the same belief system that we have as clinicians.
Right.
And sometimes it's religious, but sometimes it's secular. People who don't have necessarily belief in God may still say, well, I think we just need to give it more time. And I think that if we wait long enough, dad's a fighter. He's going to show us how different things can be. From a specific religious belief, there are beliefs in Catholicism around heroic measures, for example. Families who are deeply religious in a Catholic religion, for example, may cite certain types of encyclicals or other things that they find are particularly helpful.
Yeah.
Folks who are Jewish, and it depends on, Judaism has a lot of different faith beliefs in it, depending on kind of where you are in terms of how you interpret the scriptures. But there's this concept of the flickering flame, and that, we shouldn't do anything to disturb someone who's dying, because what if it hastens their death? And that's something that we should not do. We should avoid.
Yeah.
So there's, we meet people from lots of different faith traditions. Always try to honor those things, but we also, whatever your belief system, we still need to reach a decision of some kind together. We also see that sometimes we have families where, whether it's for religious reasons or whether it's for reasons that they don't articulate to us, they don't want to make a decision on their own because they don't want to feel responsible for the death of the person they love. Yeah. And that's something that I find is often present, where, what a profound responsibility to say, okay, I think you're right. I think it's time for us to remove this ventilator. That's what an outrageous, difficult thing that we ask families to do. And again, for folks who work in a hospital, for folks who work in critical care, these things are normalized in a way. And yet every time we have these conversations, we have to help bring a family with us and bring the loved ones, the friends, the people who are making these decisions for critically ill people. For them, it's oftentimes the first time, And we hope the only time in their life that they'll ever have to face something like this. And there are times when I think families who are in that position where they just feel like they can't make a decision, that making a decision is counter to their own moral compass.
Right.
Sometimes families are relieved when we recommend an unshared decision. Now, that is not a universal experience by any means, but there are absolutely families that are grateful to not have that choice be theirs.
Yeah, that makes sense. And I didn't think about it that way, but what a hard thing to, make that decision for your family member and to, perhaps live with that regret for a long time. And I assume in that case, it might be helpful when there's a strong recommendation one way or the other, maybe for some people. Is there cases in ethics, you probably have them, and I've had some cases in pediatrics, where you want to give some sort of care and there's resistance to that care, like where you think care would be helpful and the family may not believe it. And how do you deal with those and how do you navigate those?
Yes and yes.
Yeah.
In adults and in kids. One thing I would say is I don't personally like the language of like withdrawing care. I think we should always be providing care. It's just that care might be different.
Yeah.
There are families who request or insist upon or demand treatments that we don't think are effective. And those are challenging, especially if families say that the misinformation and disinformation beliefs that get brought are the ones that are the most challenging for me personally.
Right.
Because it isn't something where I can share data. We're not having oftentimes a shared experience of reality. So that can be very challenging.
Yeah.
Pardon me. So it depends on what the situation is. In general, we really rely on whether it's parents or whether it's surrogate decision makers to do what's in the best interest of the patient, or in the case of adults, we ask people to do a substituted judgment. We say, well, what do you think Saba would want? It's not about what you would want, but what would she want?
Yeah.
When you think about who we have an obligation as clinicians to not do things that we don't think they're not going to work. If there's no evidence for a treatment, if it's something that has zero harm potential, that's one thing. But there's a lot of things that people ask for that actually could be harmful with families. Well, and I've worked with adults and pediatric patients' parents where, they refuse chemotherapy for a highly treatable cancer. It's very stressful. It's a very stressful thing to navigate when people come believing, for example, that all chemotherapy is poison. And they don't, they think, we're going to do a ketogenic diet and that's what's going to make the cancer go away. And I wish that there was evidence that a simple diet change, while challenging, would be this big monumental thing that would make your cancer go away.
Right.
But, there's a lot of really valid criticisms of medicine and the way that we talk to people and the way that we reach decisions.
Yeah.
And we've also done a lot of really amazing things. We're lucky to have access to the pharmaceutical medications that we do that can actually treat some of these diseases that even if you think back to when, I imagine, you and I were in medical school, the advances that I've seen in the course of my career alone are so reassuring.
Yeah.
Because it's one less person each time that you're going to have a family say goodbye.
Yeah. Yeah. Yeah.
So I would say that it's the misinformation and disinformation has been the hardest for me.
Yeah. Yeah. And for a lot of us, I think, in current times. Yeah.
Yeah.
So thank you for highlighting that. Is there any language, so we talked about not saying futility. Is there any other language that you think is clinicians should be aware of using or not using?
It's so funny. I think there's so many things that we say that we don't think that they're jargon, but families have no idea what they mean. And for example, the concept of comfort care, for example, that was a language that started to become more popular, I don't know, 10 or 15 years ago, maybe. And it doesn't mean anything. And I'm not saying like, oh, don't ever say comfort care, but like translate that into Mandarin. It doesn't mean anything in Mandarin either. Translate it into Spanish. It doesn't mean anything in Spanish either. So I think just have to be, I will speak for myself. I am constantly trying to think of how can I describe things in a way that is accurate, that is straightforward, and that makes sense.
Okay.
And how do I check for understanding? Because we have so many families, they don't want to upset us, right?
Yeah.
I mean, we know that if clinicians don't like their patients, we know that they're less likely to come into your room. They're less likely to talk to you. And so a lot of patients, they want to be liked and they want to be seen as smart. I mean, that's the other thing too. It's so intimidating, right?
Yeah.
I mean, I'm very proud of becoming a physician, and I really like being a really intellectual person who gets to also do this like cool stuff.
Oh.
And it is so intimidating for people. I don't even like to tell people outside of in the hospital, I tell people I'm a doctor. But when I'm outside the hospital, I don't really want to talk about being a doctor because you'll see people like shut down. Even the concept, they're like, oh, well, I'm not smart enough to talk to you, which I think is ridiculous.
Yeah.
Because I think that there's many ways of being smart. There's many ways of knowing, and patients and families are the experts on their experiences.
Right.
And so I'm just constantly working on my ability to pay really close attention to the people I'm talking with for signs that maybe it's not totally clear.
Yeah.
And really trying to make myself smaller and try to flatten the hierarchy. It's very hard because I work for the patient when I'm taking care of them.
Right.
And I want to make sure that I might use, this is funny. I'm guessing you've been in this situation before as well, but like, sometimes you get asked to take care of a clinician, like another doctor or another doctor's child, for example. It's a very different conversation if I'm doing like a pre-anesthesia consent with somebody who's a PACU nurse or somebody who's an anesthesiologist or somebody who's a surgeon, somebody who works in the ICU. Like these are different conversations than if it's somebody where no one in their family has ever needed anesthesia before. They've never had that experience before. Maybe I'm having that conversation with an interpreter. Maybe I'm having a conversation with a family where their line of whatever they do for labor and to put food on the table is completely different.
Yeah.
First of all, I love getting to know those people because I love hearing about total different ways of being that are very different from what we do.
Yeah.
But it's also that I have to know what kind of a conversation I'm in order to be an effective communicator. And that's actually on me. Oh. That's not something where like all of the patients need to suddenly understand what I say and why is it that they don't understand this language that I'm using.
Yeah.
And I think, I think of the word comfort care or the phrase comfort care a lot because it sounds so nice.
Yeah.
And it doesn't mean anything.
Yeah.
And so we also have to describe, even when we're using these terms that are not themselves jargon, they function in a way that's jargon. And so you kind of got to keep checking in with people about, do we have a shared understanding of what's going on?
Yeah.
And to our to talking earlier about conversations in the ICU, conversations at the end of life. I mean, that's a big thing. Do we have a shared understanding of what's even happening? And if we don't, how can I identify where those tension points are so that we can work through those together? And because I don't want to give up a trusting relationship with a family, and I don't want these disagreements, arguments, lack of consensus to be something that damages that relationship. As clinicians, I think those are opportunities oftentimes for us to lean into those relationships, lean into the trust, lean into being a trustworthy person, being a trustworthy agent, especially when so many people have been violated and harmed in medicine.
Yeah. And you're right, like there's such a big shared decision making, like if we have shared understanding, because often there's such a huge disconnect between and we've all seen that, what the patients are thinking. I think they're focused on something else. The provider is focused on something else. So
when I've taken care of I take care of a lot of patients who are immigrants, and some people immigrated here a long time ago. Some people immigrated more recently. I have learned so much about other countries' health systems by the kinds of questions that families will ask. Because, like, I'll say, "Oh, well, tell me what this would have been like in where you just moved here from." And especially, there's certain countries where it's like, it is so different. Like, I don't have any concept of how this family thinks about getting care because the system that they have come from, so, whatever it is, some like Ministry of Health, whatever. I actually need to learn from them so that I can then understand what are the things about this system that make no sense to them.
Right.
I mean, the number of times I've had families who are, parents are recent immigrants. We're using an interpreter. We have to use one on the phone because it's some very unusual language, which is very challenging. And we're like, not only are we literally not speaking the same language, we are coming from completely different cultural and social contexts.
Right.
And so I just tried my best to lean into that and to be curious.
Yeah.
To try to figure out where can we build those bridges so that we can understand each other as best as possible.
Yeah. I mean, that's a great point because I think often, like, without understanding, we try to impose what our understanding and our system is, like, without understanding that context because we think this is the best way to do it.
Yeah.
And it's in ignorance. Like, I've done it so many times too. So, yeah. It's a
well,
good
and it's also, I would say, challenging with, this concept of cultural relativism, right? Like, well, if it's their culture from some other place, does that mean that we will do whatever this family says or does? And it's like, well, no. I mean, we still have our obligations. We still have our ethical obligations. We have legal responsibilities, so we're still bringing, this family's still in this context of this American healthcare system, but how can we navigate this process together in a way that really centers the patient's dignity?
Yeah. No, that's a great point. And you talked about the law, like just pivoting a little bit. How does the legal system, kind of incorporate into the ethical decision making? And when does that have to get involved just for our listeners who are clinicians?
Well, first of all, I mean, in general, I think that if a clinician ever thinks, maybe I should call risk management, or maybe I should call my carrier for my malpractice insurance, make the call. I've never regretted learning a little bit more information or getting reassurance, depending on what it is. I think there's a lot of, like, the ethics and the law, it's like a Venn diagram, but they're not a perfect circle. There are things that the law simply is silent on. There are things that the law doesn't talk about. And so we rely on our ethical analysis. We rely on this other way of knowing, this other way of thinking in order to think about what we're going to do. But there's also, if you look at, obviously we have a bunch of things happening in America right now where I'm like, well, the law seems pretty unethical sometimes. Telling me as if you're a physician in Texas and you have a patient who shows up who's having a miscarriage and your legal counsel is like, well, you're just going to have to let her bleed out in the parking lot until she's close enough to death that you can definitely say it's an emergency. I mean, that is absolutely unethical, and it is technically legal. And so I think as clinicians, if there's any clinicians listening who are like interested in being a politician, you're interested in talking to politicians and helping them understand what our lives are really like, we need clinicians who really understand what's going on and can really center the ways that the law negatively impacts people we care about.
Yeah, no, that's a great point. I think we need more clinicians there in that space. Have you, just talking about clinicians or healthcare workers, if they're feeling, I want to talk about the moral distress, and I know you talk a lot about the moral injury piece. Do you feel, asking you personally, like uncertainty in these decisions, and does that bring like moral injury, burnout to healthcare workers?
Yeah, I mean, I think moral distress and moral injury is a major part of what leads to burnout, and there's several studies that show that connection. And for folks who may or may not be aware, moral distress is a concept that came out of really the nursing literature from a gentleman named Jameson, who really identified this concept that nurses who felt that they knew the right thing to do, they knew the ethically right thing to do, but they were stopped from doing it because of a policy or a physician didn't agree with them and didn't write an order or whatever. There's all sorts of ways we can think about these scenarios. But if you feel like you know the right thing to do, but you are constrained in some way from acting in alignment with your integrity, that leads to distress. It makes us uncomfortable. For people who, when you get asked to do something that makes you uncomfortable because you think it's wrong and you get a stomach ache, like this is a manifestation of moral distress. Your body is telling you something.
Yeah.
And moral injury is a concept that comes out of the military, especially in the context. There's several interesting books that were written by a gentleman named Jonathan Shea talking about moral injury in, soldiers who returned from war who had done, they've killed people, they've burned down villages, like whatever the things are that they were told to do, and they felt constrained from saying no. And sometimes it's just witnessing. You witness a terrible event that should not have happened.
Yeah.
That can violate our deepest sense of who we are.
Yeah.
And so this is an important, I think this comes up a lot in, just thinking about our concept of medically ineffective treatment. The reason that we talk about medically ineffective treatment is because people in the ICU, people who are doing this, life-sustaining therapies are moral agents. And they don't want to be doing things to patients if they're not helpful and if they're not going to make it possible for the patient to leave the ICU and to recover. And so, and there's certainly criticisms of this process of medically ineffective treatment and whether it should ever be allowed for us to override a medical decision maker.
Yeah.
But it is really trying to get at this clinicians as moral agents, and what do we do in this concept of if you are telling me I'm giving you all this expertise, I know that this patient is so unlikely to survive this hospitalization that I truly think there is no other correct decision but to stop the ventilator, to stop the blood pressure medications. But if you have a family that's still insisting that those things continue and they want to continue them indefinitely, then you, as a clinician, you understand that this patient is continuing to get sicker and sicker. At some point, their heart is going to stop. And not only will I not have been able to prevent that from happening with all of this therapy, now I'm going to have to do chest compressions to this person who I know will not survive that either.
Yeah.
And so, this is, I think, that compounding moral distress and moral injury that, nurses and physicians and social workers and, all these people who make it possible for us to provide care in modern medicine are really shouldering that pain. And want what's best for patients. And it's very hard to realize that despite all of these advances in modern medicine, that we can't save everybody. We wish we could.
Is there a way you cope with it? Because I know you've talked about it on your Instagram and,
about moral injury?
Yeah. I don't know if you have any good tips or hope for the clinicians who are facing.
One, I would say that if you're experiencing moral distress and moral injury, you're not broken. That's a good sign, in my opinion. It's unpleasant. I'm not wishing it on anybody.
Mm-hmm.
But when we have the capacity to realize that we are living in the tension of the ethical tension of our experience and what we're being asked to do, that means you're not broken. It means that your integrity is still intact. And so how can we manage that tension in a way that keeps us whole as human beings? I think that the practice of medicine, and again, I love being a doctor, but it's traumatizing.
Yeah.
Being a nurse is traumatizing. We do and we see things that are illegal in any other context.
Mm-hmm.
Because what we do is weird.
Yeah.
It's weird. Being a healthcare worker is... But I think we forget, right? Because you think about, I don't know about you, God, I wanted to be a doctor so bad. It was this beautiful thing that I really, really wanted. And as many people who became doctors worked very, very hard to get into medical school, worked very, very hard to get into residency. And it's so funny. My girlfriend says, why did we get everything we ever wanted? Why did we achieve all of these dreams? And because it's like doing the actual work can be really hard in ways that change who we are.
Yeah.
And so, I would say for clinicians who are experiencing moral distress, you're experiencing moral injury, that's something to pay attention to.
Yeah.
It's like when you notice the pain in your body, you're like, oh, maybe I need to do something about that.
Yeah.
It doesn't mean you're going to have all the answers. There are, if you are interested in learning more about it, check out Moral Injury Clinic. My Substack, I'd be, happy to chat with you too. We have to find ways to realign ourselves with who we are and the versions of ourselves that we want to be. There's a lot of really great, this is also something too, I think a lot of times in medicine, we get so siloed.
Yeah.
Like, once you become whatever you're going to be, or like you just kind of stick to that literature. The nursing literature has a lot to offer about moral distress. Cinda Rushton's an incredible ethicist and a nurse ethicist. She has a PhD. She's done a ton of really cool work looking at moral injury and moral distress, and specifically in nurses. But guess what? We're not that different from nurses.
Yeah.
We are not like fundamentally totally different. Like, we are all human beings who are trying to do this really difficult work together. So I personally find work from the nursing literature to be very, very helpful. I also find work from the military context to be very helpful. And so I think these are areas that we can lean into. And from a lifelong learning standpoint, I find it so valuable. I find it so valuable to say, okay, who is looking into this and how might that apply in the situation that I'm facing?
Yeah, that's awesome. Yeah, thank you for sharing those. I think if you have any resources, just send them my way and I can link them in the show notes. I think we're almost wrapping up towards the end in terms of medically ineffective treatment. For our listeners, are there any resources, or do you think clinicians would do better, or do you have any message for them as we wrap up this podcast?
Yeah. Well, one, I think that the Society of Critical Care Medicine guidelines are, it's really foundational to the way that I think about this. And so I can make sure to send you a link that we can put in the show notes as well.
Okay.
And I think that, again, this concept of, I worry sometimes that we use control when we are uncomfortable. We want to say, oh, well, I don't like the decision this person is making because I think it's wrong, and I want to make them make a different decision. I don't think everybody thinks about it that way, but I've certainly noticed some clinicians. And I believe that that is a manifestation of the moral distress and moral injury of doing this very difficult work.
Yeah.
And so I try to help reorient clinicians who are considering invoking medically ineffective treatment to really think, okay, how would we approach this situation in a trauma-informed way? How do we best understand the situation that this family is facing, that the situation this patient is in, so that we can try to build up the trust and to lean into the relationship rather than to abdicate out of the relationship. So medically ineffective treatment, it's supposed to be something that's rare. It's not supposed to be something that we need to invoke often.
Yeah.
And I think critical care physicians in all branches of medicine are doing really incredible work. I'm constantly impressed at the difficulty that they're managing, not only procedurally, but having these super difficult conversations.
Yeah.
And sometimes we really do reach an intractable disagreement, and medically ineffective treatment is a helpful way to think about how do we approach that too.
Yeah. Well, thank you so much for doing this with us today. I think I learned a lot. I think our listeners will learn a lot. And really, I think we don't talk enough about these things. We don't learn enough about these in medical school. And so I think any information that we got from you today is really, really helpful.
And there's so many things we didn't learn in medical school. We have to keep learning. It never stops.
Yeah. No, I agree with you on that. Yeah, it's just you got to learn. I don't think we learn a lot about death and dying. Like nobody teaches us how to process that or that it's going to happen. And specifically didn't learn that in Pete. So it was like a rude awakening. Very, very rude. Yeah. As we close this conversation, we have a tradition on the podcast. We just end it always with a poem. So if you'll stay with me for that, and then we'll end.
Okay.
We're reminded that end of life, it's just not a medical moment. It's an ethical, emotional, deeply human one. And sometimes the most compassionate thing can be to step back and to recognize that more treatment doesn't always mean more care. And the poem is by Mary Oliver, and it reminds us that how we die and how we care for the dying reflects how we've lived. And it's called When Death Comes. So when death comes like the hungry bear in autumn, when death comes and takes all the bright coins from his purse to buy me and snaps the purse shut, when death comes like the measles pox, when death comes like an iceberg between the shoulder blades, I want to step through the door full of curiosity, wondering, what is it going to be like, that cottage of darkness? And therefore, I look upon everything as a brotherhood and a sisterhood. And I look upon time as no more than an idea, and I consider eternity as another possibility. And I think of each life as a flower, as common as a field daisy, and as singular, and each name a comfortable music in the mouth, tending as all music does towards silence, and each body a line of courage and something precious to the earth. When it's over, I want to say all my life I was a bride, married to amazement. I was the bridegroom taking the world into my arms. When it's over, I don't want to wonder if I have made of my life something particular and real. I don't want to find myself sighing and frightened or full of argument. I don't want to end up simply having visited this world. Thank you so much, Dr. Burgart, for doing this with us today.
Thank you. It was really great being here.